So I actually think that the clinical trial data underestimate the extent to which acalabrutinib is so much better tolerated by patients than ibrutinib. That much of the general malaise and fatigue that can afflict a significant percentage of patients on ibrutinib, you just don't see. I also haven't seen any cardiac toxicity, although we do have the Elevate trial, which had about a 3.5 to 4% rate of atrial fibrillation compared to 0.5% in the obinutuzumab chlorambucil arm. But still, with the 2.5-year follow-up of that trial, you would expect AFib with ibrutinib patients to be 10 to 15% at least.
Yeah, no, I agree. In my clinical experience, that it's a much better tolerated drug. Unfortunately, we have to still wait for the head-to-head data to compare more efficiently and statistically, but certainly in clinical experience is better. One thing I have not seen significantly with the acalabrutinib is the joint pain and arthralgias that I see a lot with the ibrutinib, and tends to be something that it's really dose limiting for those patients. The most common side effect of acalabrutinib tends to be the headache, and fortunately it's fairly well controlled with the use of caffeine. I tell my patients to drink coffee in the morning with their acalabrutinib. It's a twice-a-day pill. It's given 100 milligrams twice a day. And it tends to overcome the headaches. This is front-loaded, so in general you see that in the first couple of months, and it tends to go away. A little bit of diarrhea in the beginning as well, but that tends to go away after a couple of months, but it's fairly well tolerated. Again, the only reason to decrease the dose off the bat is the same reason as opposed to ibrutinib, is a CYP3A4 metabolized drug. So remembering the medications that can interact with that, particularly some antihypertensives can interact with CYP3A4, and lots of times we forget about those, especially in the older population, and remembering that patients should not drink grapefruit products or star fruit or Seville oranges, which no one eats because it's very bitter, but it's in marmalade, it's an orange marmalade, so we should stay away from that.
On that note, actually, another important issue with acalabrutinib is that if people are on PPIs, it does decrease the absorption of acalabrutinib significantly, which is in contrast to ibrutinib or the newer drug zanubrutinib, which is not approved for CLL, but did get an approval for mantle cell lymphoma earlier this year.
Yeah, that is correct. Acalabrutinib requires an acidic environment in the stomach to be absorbed. So in general, we change the patients from PPIs to H2 antagonists, but those have to be given spaced out from the acalabrutinib as well, not to interact. So it's on the package insert of the drug. As much as patients can take Tums and things like that, because a lot of people are on PPIs, not strictly for the right indication. So if we can change them to other kinds of antacids that can be taken PRN, that's appropriate as well.
And on the subject of, so I have actually seen patients with arthralgias on acalabrutinib, but it tends to be much more transient and much less dose limiting than with ibrutinib, which is how I also feel about the bleeding. You still see it, but it's less of a problem, and the GI side effects.
Yeah, absolutely.